The Mobile Urgent Care Service visits patients that are acutely unwell, who are frail and housebound and are unable to attend their GP practices. They're acutely unwell on top of their comorbidities that they already have.
On a typical day, if we had a patient requesting a visit, that patient would phone in, or their carer would phone into the surgery. That patient would be triaged, which is a conversation between the GP and the patient, or the GP and the carer, depending on the situation. And then prior to this service, that patient would have been visited usually after morning surgery, so this often into the early afternoon. If we have a visit request come through during the afternoon, that would often mean the visit was deferred till very late in the day, often after evening surgery, looking towards 6:30, 7 kind of time. This patient group now can be triaged, and the appropriate patients can be referred to the Mobile Urgent Care Service, and that enables a visit much earlier in the day by a team that are specialists in managing our most complex patients. They're co-located with a variety of community services, which means that they've got more rapid access to a broader range of services. That will allow them to either treat the patient more promptly, to mobilise a response earlier in the day, which makes it much more possible to get an appropriate response, or if that patient does need to be in hospital, the patient can be transferred to hospital in a much more timely fashion.
The cases that we would see are often urgent because they will impact on their existing chronic problems, their chronic comorbidities. So we would see some symptoms such as urine infections, chest infections, but it can go all the way through to sepsis. So a timely visit is really important to these patients. Currently there are 2 nurse practitioners who carry out these visits during the day. So this is myself and my colleague Kate. And we have backgrounds of community working. Both of us were community matrons. Kate's also worked in a GP practice before, and I've been a respiratory nurse specialist in secondary care. So we have quite a breadth of experience to go out and visit these patients and do thorough assessments. But that's only the visiting side. We also have frailty assistants that we work very closely with, and also our health and social care coordinators who take the calls and allocate the visits. We also have very good links with Radipole ward at West Haven. So if we felt that a patient needed to have some further support and rehabilitation, and they had a capacity at the community hospital, we often communicate with the ward and ask if they can be admitted directly to the ward rather than an acute admission, which can often be detrimental to a patient that's got dementia or is frail. So we discuss with the ward, and we try and get them admitted directly to the ward for rehabilitation.
I've been involved in the development of the Weymouth and Portland Frailty Service right from the beginning in April 2015. And over the last 4 years we've been able to develop a locality-based service rather than in groups of surgeries working together. We're now at a point where the whole locality is working in the same way for our frail patients. This means that we can provide proactive care and routine care for these patients, and it's been really rewarding to see how the service has managed to develop with the support of colleagues in primary care and in community services. Being based, co-located at West Haven's been vitally important for progressing this, and that gives us easier links with the MUC service as well and with the integrated hub.